Good afternoon. My name is Allison Bauer, and I'm one of the third-year fellows at the Combined University Hospitals and Metro Health Maternal Fetal Medicine Fellowship Program. I would like to start by thanking the Cleveland Society of OBGYN for the opportunity to present our work entitled Mortality and Hospitalizations for Gunshot Wounds in Pregnancy, a retrospective cohort in the National Inpatient Sample 2007 to 2014. I have no conflicts of interest to disclose. To provide some background, the United States leads all high-income countries in mortality from gunshot wounds, and gunshot wounds are a leading cause of morbidity and significant healthcare costs. A study of mortality during hospitalization for gunshot wounds found that women were less likely to be hospitalized for a gunshot wound compared with men, but the women who were hospitalized were significantly more likely to die during their hospitalization. Furthermore, numerous publications have demonstrated an increased rate of intimate partner violence in pregnancy. Therefore, given that intimate partner violence is increased in pregnancy and mortality from gunshot wounds may be increased in pregnancy, pregnant women are also at risk for firearm violence. Finally, the characterization of contemporary incidents of gunshot wounds and outcomes in pregnancy is pertinent to public health. The objective of this study is therefore to evaluate the incidence of firearm-related mortality in pregnancy. We hypothesize that firearm-related mortality will be more frequent in hospitalizations of women who are pregnant compared with women who are not pregnant. Next, we will review the methods. We performed a retrospective cohort study using data from the National Inpatient Sample, which is a large, publicly available, all-payer inpatient healthcare database that contains data from more than 7 million hospital stays each year. Weighted, it estimates more than 35 million hospitalizations annually. The National Inpatient Sample contains de-identified patient data, including demographic characteristics and International Classification of Diseases 9th and 10th edition diagnosis and procedure codes. This study was determined to be exempt from IRB review by our institution. The study period utilized was 2007 to 2014, which contained data on more than 61.4 million hospitalizations, approximately 20% of all admissions annually. Comparison groups included pregnant versus non-pregnant women hospitalized for gunshot wounds in the study period. Reproductive aged women aged 15 to 45 years who were hospitalized for gunshot wound were identified. ICD-9 diagnosis and procedure codes were used to identify pregnancy and all other outcomes of interest. Ectopic pregnancies and pregnancy terminations were excluded. The primary outcome of interest was maternal mortality, which we defined as death during hospitalization. Secondary outcomes assessed included a composite maternal morbidity during hospitalization and intent of injury. Composite maternal morbidity included shock, sepsis, blood transfusion, disseminated intravascular coagulopathy, venous thromboembolism, need for mechanical ventilation, laparotomy, or hysterectomy during hospitalization. The intent of injury was also identified and included suicide or self-inflicted, assault, unintentional injury, or undetermined intent. Demographic characteristics were obtained and compared between groups. Rates of maternal mortality, composite maternal morbidity, and all other outcomes of interest were compared between pregnant and non-pregnant women with univariable analysis. All univariable analyses were performed using Fisher's exact and Wilcoxon rank sum test where appropriate, with a p-value of less than 0.05 being significant. Given multiple possible confounding variables, including demographic characteristics, stepwise multivariable linear regression analyses were also performed for maternal mortality and composite maternal morbidity, with retention of all variables with a p-value of less than 0.1 in the final model. After stepwise elimination, age and pregnancy were no longer significant in this model, but associations with African American race, private insurance, suicide, and unintentional injury persisted. These results are presented on tables 1 and 2 as an adjusted odds ratio and 95% confidence intervals. Finally, we examined the trend of gunshot wounds in the setting of pregnancy annually throughout the study period. Now we will review our results. A total of 3,882 hospitalizations for gunshot wounds among reproductive aged women were identified during the study period. 181, or 4.7% of these, were associated with a pregnancy. Demographic characteristics of the study population are depicted here in Table 1. Of women hospitalized for a gunshot wound, pregnant women were significantly more likely to be younger, more likely to be African American, and less likely to have private insurance. Pregnant women were also less likely to be diagnosed with pre-existing diabetes, a mood disorder, or alcohol use compared with non-pregnant women. Of note, in order to maintain patient anonymity, the National Inpatient Sample prohibits publication of a cell containing 1 to 10 patients, and these cells are annotated in this and following tables as containing less than or equal to 10 patients. Table 2 depicts the primary and secondary outcomes. Pregnant women hospitalized for a gunshot wound were significantly less likely to die during hospitalization compared with non-pregnant women, though this association did not persist in multivariable regression. No differences in individual morbidities or composite maternal morbidity were observed between groups. However, on evaluation of intent of injury, pregnant women were significantly more likely to experience an unintentional injury with an adjusted odds ratio of 3.8, and significantly less likely to experience a self-inflicted injury with an adjusted odds ratio of 0.6 compared with non-pregnant women. These associations did persist in multivariable regression. Finally, the temporal trend in hospitalizations for gunshot wounds among reproductive aged women was analyzed. In this graph, data is presented as percent of women aged 15 to 45 years who were hospitalized for a gunshot wound along the y-axis, by year along the x-axis. In all years, non-pregnant women were significantly more likely than pregnant women to be hospitalized for a gunshot wound, with a p-value of less than 0.001. Annually, the rate of hospitalization associated with a gunshot wound in reproductive aged females remained stable at 0.02% across the study period. Rates of composite morbidity and death during hospitalization for a gunshot wound were low in pregnant women in all years, less than or equal to 10, and not significantly different compared with non-pregnant women. The strengths of our study include the use of a large national database to allow meaningful evaluation of rare outcomes. Limitations of our study include the inherent limitations of a retrospective study, being able to identify association and not causation. Furthermore, the National Inpatient Sample is a de-identified database that captures data during hospitalizations. We were therefore unable to assess individual patient characteristics or neonatal outcomes that may have been pertinent, and were also unable to assess any mortality that occurred prior to arrival at a hospital. In conclusion, we found that hospitalizations for gunshot wounds in pregnancy remained stable with low overall mortality rates between 2007 and 2014. We also found that pregnant women were significantly less likely to die during hospitalization for a gunshot wound compared with non-pregnant women, and that there is no significant difference in morbidity associated with gunshot wounds in pregnant versus non-pregnant reproductive aged women. Finally, pregnant women were significantly more likely to experience an unintentional injury, which may support the need for further gun violence research and public health interventions. I would like to acknowledge and thank my co-authors and research mentors for their support on this and many other projects, including my co-fellow Dr. Nash Putra and Dr. David Hackney, pictured here, as well as Drs. Justin Lappin and Dr. David Shane, who could not be with us at this presentation. This includes a brief list of pertinent references used for this presentation. Finally, given the virtual format, please do not hesitate to reach out by email with any questions or comments, and I thank you for your attention.